All right, so I'm going to begin by giving a brief history of how the procedure was developed, and we'll talk about a variety of different surgical positions that can be used. There's one of the kind of hot debates in percutaneous renal surgery for the last decade or so, or even longer, and also more recently, has been what is the ideal position? Should we be doing these patients in the prone position or supine? And there are a variety of different reasons why we may argue for one versus another. And these usually fall into a number of categories, such as physiologic changes that occur between the prone and supine positions, so I'll talk about that. As Dr. Okanov already alluded to, there are a variety of changes in anatomy that can occur when you transfer the patient. So I'll talk about a variety of studies that have looked at that. There are also some technical considerations, and then more importantly, well, what does this mean for your actual practice? So what does the data show? And there have been a number of comparative studies that have looked at these positions and outcomes, and I'll review those studies. So the first nephroscopy was performed in 1941. This was actually during an open surgery in which a rigid nephroscope was then inserted into the kidney, and stone was extracted. And then I guess I would say, Dr. Smith, if I get any of this wrong, please let me know. And then in 1955, the chairman at UCLA, Dr. Goodwin, actually performed the first neph tube placement. So he was actually trying to do an arteriogram and punctured into a nephrotic or hydronephrotic collecting system and performed the first actually antegrade nephrostogram, and ended up leaving a tube in the kidney. The first actual intended percutaneous stone extraction was back in '76 with Fernstrom and Johansson. And then Dr. Smith performed the first antegrade stent placement in 1978, and at that time coined the term endourology, which some people joked at the time was actually the end of urology. And between 1978 and 1984, there were a variety of modifications that occurred. Many of these came out of the University of Minnesota, in which they had the confluence of many great physicians, including not only urologists but radiologists such as Dr. Smith, Amplatz, and Dr. Clayman. In 1982, Dr. Clayman developed a kidney model in pigs, which was then used to help teach a variety of people not only percutaneous procedures but also ureteroscopy. In 1984, the first tubeless PCNL procedure was reported, and we'll talk, I'm sure in this course there'll be more talk about the tubeless procedure, but this simply refers to omitting a nephrostomy tube. So oftentimes patients will still have a ureteral stent placed. And then in 1987, the first supine percutaneous nephrolithotomy was reported by Valdivia. And then in 92, there was a series of endocasts that were created, and there's a picture of it here. And that greatly expanded our knowledge of, so in the next talk I'll be talking about ideal percutaneous access. And by doing these endocasts, that really helped to define not only the collecting system anatomy, but also its relation to the vascular system, and help to greatly expand the safety of these procedures. So getting back to positioning, at present about 80% of PCNLs are done with the patient in the prone position, and about 20% are done with the patient supine. But there are a variety of different positions, even in the prone or supine position. So you can do what's called pure prone, prone flexed, modifying prone flex, prone split leg. I'll show some of these and talk about them. You can do the procedure with a patient in the lateral position, with the table flexed, not flexed, supine, in which they're just completely supine on the OR table. You can place a 3-liter bag under the ipsilateral side to bump it up. There's the Valdivia, the Galdaco modified Valdivia, and the Bart's position. These latter positions are done primarily to help facilitate combined retrograde intrarenal surgery along with percutaneous surgery. So this is pure prone procedure. So basically, the patient is either just flat on the OR table, or oftentimes they'll have bumps under either side, which helps to elevate the chest off of the OR table. So that way, this helps free the chest up and hopefully decrease the peak inspiratory pressure when the patient's being ventilated. It's important that their arms are not abducted any more than 90 degrees, either at the elbow or at the shoulder, to help prevent brachial plexus injury. There's the prone flex position here, which is basically very similar, and either they're put under a wedge or the table can be flexed, and there are a variety of potential advantages, which I'll talk about a little bit later in this procedure. And this has been popularized by Dr. Honey. There's the prone split leg procedure, and one of the purposes of this position is One of the arguments against prone by the people who do supine is that they argue that they can do this combined ureteroscopy and percutaneous procedure. And by doing the prone split leg, this gives you access to the urethra so you can do a combined ureteroscopy while doing your perc. There's the lateral decubitus position. This is primarily used for patients who are morbidly obese and who cannot tolerate going into the prone position due to these physiologic changes that occur. In addition, if you try to do these patients supine, the pannus or their abdominal fat will kind of spread out and will make the tract length between the skin and the stone very long, which makes it almost impossible to get into the kidney. So by putting them into the lateral decubitus position, their abdomen is able to get out of the way, and there are fewer physiologic changes. This is the supine position, in which you have the ipsilateral side bumped here under usually like a 3-liter saline bag. And then this is the Galdaco modified Valdivia position, in which you have a bump under the hip and the shoulder, freeing up the area that you're going to go into, and then you have the patient in a modified type lithotomy position. So that way you can have one surgical team doing ureteroscopy while the other team is performing the percutaneous approach. One of the primary advantages of this combined approach is that it hopefully allows you to clear complex stone burden without having to make multiple punctures. And if there's a stone that's not accessible via your initial access tract, the person who's doing a ureteroscopy can either laser that stone or grab it and then relocate it such that it can be extracted through the percutaneous tract. Now, there are a variety of different types of advantages and disadvantages based upon the patient's position. So let's start with the lateral position. This is the one that's used less. And I've referred to this a little bit already. So this is really the ideal position for patients who are super morbidly obese. And it can also be used in patients who have complex skeletal deformities that really can't lay supine very easily, or certainly can't be transferred into the prone position. And sometimes this is really the ideal way for them to be done. In addition, there are fewer physiologic changes compared to the prone position. And there have been a variety of reports that you can do this while the patient's on monitored anesthesia. And so this is for patients that are just really quite ill but have no other good alternative other than a percutaneous approach. There's a variety of disadvantages. One, the patient has to be repositioned. Now, they're not being repositioned as much as when you're putting them into the prone position, but you're still moving these very large patients. There's a risk of pressure injury, either to nerves or rhabdomyolysis, in which you're getting muscle breakdown because this entire body weight is being concentrated on a very small surface area. And then most urologists who are obtaining access with fluoroscopy are accustomed to either doing it in the prone position or in the supine position, and a lot of us aren't doing it very frequently in the lateral position, so it can be a little bit more challenging just because we're not comfortable with it. Now, with regard to the prone position, as I said, about 80% of PCNL is done in the prone position. There are a variety of advantages and disadvantages. So there are more access options. So when the patient's prone, you can basically go into the kidney anywhere from above the ribs all the way down to the posterior superior iliac spine. But when the patient's in the supine position, what you typically do is you'll do an access between the inferior margin of the ribs and the iliac crest. And you can see this is a relatively narrow window to try to get into the kidney. In addition, it makes it challenging to get into the upper pole of the kidney, and if you're doing that, you have to come in at an oblique angle as opposed to going straight down into the upper pole. The access tract, because you're going straight down into the kidney in the prone position, tends to be shorter. The kidney's less mobile. Well, why is that? So the back is relatively inflexible. So when you're laying supine, none of the pressure from the OR table is really being transmitted to the abdominal contents. When you transfer the patient over into the prone position, the anterior abdominal wall is very compliant. So all that pressure from the OR table and gravity is being transduced into the retroperitoneum, and so basically fix the kidney into place. So once you have your wire into the kidney and you go to try to dilate the tract with, let's say, sequential dilators, the kidney's not moving away. Whereas when the patient's in the supine position and you're trying to pass an Amplatz dilator or a metal telescoping dilator, the kidney often wants to move away because it's not pinned into place. And that can oftentimes create challenges, and frequently wires can get kinked or can get lost. In addition, you can have better visualization in the prone position. Well, why is that? What you'll see is if the OR table is here at the bottom of the screen, your access tract is oriented in such a way that it creates a column of water, and the irrigation tends to be retained within the collecting system, so the collecting system gets dilated so you can see better. Now, there are also a variety of disadvantages. You have to reposition the patient. And in the United States and in many parts of the world, there's this increasing epidemic of obesity. And it's challenging and it's dangerous for the operative staff to move these big patients. There's a risk of pulling out lines, endotracheal tubes when you're transferring the patient, as well as just physically injuring the patient themselves. And then a variety of physiologic changes which can occur, and I'll talk about that shortly. Also, there's a potential for increased radiation exposure. So as you're getting your access, your hand is potentially right under the in the path of the fluoroscope. And just last week alone, working with residents, I had my hand irradiated twice by the residents. So it can definitely occur. Whereas when you're doing this in the supine position, your hands are not within the fluoroscopic field. As was mentioned before, combined ureteroscopy can be challenging in the prone position compared to supine. However, you simply just need to use the split leg device, and that will help take care of it. There's also a theory that this could increase your risk of sepsis. This has to do, once again, with the reason why visualization is better, in that the irrigation tends to be retained within the kidney because the access sheath is more vertical. That increased pressure, there's some thought that maybe it can be transmitted and cause pilovenous backflow, increase the risk of sepsis, but this has mostly just been argued, not conclusively shown. Now, the supine position, there are a variety of advantages. So there's no need to reposition the patient, so there's no potential injury to the patient or to the staff. There are no physiologic changes, and some would argue that it's more ergonomic for the surgeon. You can sit down while doing the procedure. Your hand is not in the way of the fluoroscope, so you're not going to get irradiated. And as they talked about, it can facilitate combined ureteroscopy. Now, because the sheath in the supine position is actually angled downwards, as you're irrigating, many stone fragments will actually just irrigate freely out of the kidney. And there are a variety of disadvantages. As we talked about, there's a much narrower window of opportunity for getting into the kidney, so there are fewer access options. The tract tends to be longer. The kidney is more mobile, which I talked about, and poor visualization because, once again, the sheath is pointed downward, so the irrigation is freely coming out, and so it's harder to distend the collecting system. So let's talk about physiologic changes. There have been a number of studies that have been published in the anesthesia literature looking at this. These are primarily not within the urologic literature, but they've looked at changes when a patient goes from the supine to prone position. So as I already talked about, the anterior abdominal wall is much more compliant, so that pressure is being pushed back into the retroperitoneum, and it can actually occlude the inferior vena cava. That causes decreased return of blood to the heart, which can decrease your cardiac output. But the mean arterial pressure tends to be preserved because of peripheral vasoconstriction, so your blood pressure tends not to go down. Now, a lot of the people will argue that the primary concern has to do with the lungs when you put the patient into the prone position. And in fact, actually, a lot of the data doesn't support that. So in patients who have acute respiratory distress, oftentimes these patients are purposely in the ICU placed into the prone position because there's improved ventilatory perfusion matching in the prone position. There's increased functional residual capacity. But indeed, sometimes you can get increased peak inspiratory pressures, but there are ways to get around that. As mentioned, you can put bolsters under the side of the patient to allow the chest to be able to move freely. There was a recent study published by Dr. Smith and Okiki at LIJ looking at the change in the peak inspiratory pressure in patients who were placed into the prone position. They reviewed the anesthesia logs of approximately 100 PCNLs, and they looked at the peak inspiratory pressure when the patient was supine. So the beginning of the case, when they're putting a ureteral catheter in, that first part is done supine in the lithotomy position, and they're transferred prone. And they looked at the change on the anesthesia log in the pressures. And they looked specifically at patients who were obese and patients who were not. And what you can see here is that basically, not surprisingly, the patients who were morbidly obese had higher peak inspiratory pressures compared to the patients who were not obese. But what you'll see is that there's really no significant change in the peak inspiratory pressure from when they're supine to when they're prone. So they had argued based upon this data that really a lot of these concerns that the supine PCL camp will argue really are somewhat unfounded in the urologic literature. And how about kind of shifting gears? Let's talk about anatomy. Dr. Okanov talked about that already a little bit, that there are a variety of changes that can occur. Most of the time when a patient comes in and has an acute stone event, they're getting their CT in the supine position. When we go to take them to the operating room, most of us are doing this in the prone position. There can be a number of changes. So there was a study looking at 16 consecutive patients that underwent a PCNL, and they basically looked at changes on CT. They did a CT with them supine, and then they did a CT with them in the prone bolstered position. So they had a bolster on either side of the chest, like I talked about before, to kind of get the chest elevated. And they measured a variety of different parameters. So they drew a horizontal line here through the sagittal plane, and then they basically measured a line just inferior and medial to the apex of the 12th rib, through in line with the stone in the infundibulum. And what they did was they calculated the organ to tract distance, which was, so they measured the distance here to the either liver, spleen, or organ, or colon. They then also looked at the distance between the skin and the stone, and the tract angle, which was the difference between this sagittal line, or sagittal plane, and the line in which they were going to go into the kidney. And what they found was that in the supine position, that the distance between the theoretical tract that they were going to use to get into the kidney and the viscera, the colon, liver, and spleen, was actually greater. So they argued that in the supine position there was less risk. The skin to stone distance was longer in the supine position, and the tract angle was also less. There was a study that Dr. Okanov alluded to that we did at LIJ, in which patients who were undergoing a CT urogram for hematuria actually had 3 phases that were done. So the first non-contrast phase was done with them in the supine position. They then went for the initial contrast phase into the supine oblique, so their ipsilateral side was elevated about 30 degrees, and then they actually had a CT in the prone position. And what we looked at were tract length, and we found that once again in the prone position, the tract length was shorter in the prone position compared to supine and the supine oblique. We also looked at what's called the axis angle, which was basically measured from the lateral margin of the paraspinous muscles to the liver, or on the other side the spleen, and the colon. And unlike the previous study, what we found was that there was actually a decreased risk of visceral injury in the prone position, and that the liver and the spleen seemed to drop away in the prone position. Now, Dr. Honey has popularized this prone flex position, and they did a study looking at 16 patients in the supine, prone, and prone flexed, and they once again looked at distances between the theoretical tract and the viscera. And they also looked at the distance between the inferior margin of the 12th rib and the posterior superior iliac crest. And then the third thing they measured was the upper part of the upper pole calyx relative to the 11th rib. And what they found, similar to our study, was that there was less risk of injuring the viscera if the patient was in the prone position compared to supine, and even less risk if the table was flexed. They also found that the distance, this is not surprising at all, between the 12th rib and the posterior superior crest increased as the table was flexed, which gives you more potential access options. And they also found that by flexing the table, it actually kind of pulled the upper part of the kidney down relative to the 11th rib. And so what the authors noted that in their study was that there was a potential decrease in visceral injury in the prone flex position, and an increase in the number of potential access sites because you're opening that space up. You're increasing the distance between the ribs, should you need to go between the ribs, and it also moves the buttocks out of the way such that the patient has is morbidly obese and has a lot of fat in that area. By dropping it out of the way, you're able to go into the lower pole of the kidney and be able to maneuver the nephroscope without hitting the buttocks. There's also a potential decrease in thoracic complications because they found that the kidney was moved down. And what they said was that if access was performed into the most superior calyx, this would have converted an upper pole axis above the 11th rib to one above simply the 12th rib in about 50% of patients. And one of the things that's been well established is that if you go above the 11th rib, there's almost about a 30% chance of having a thoracic complication, either a hydro or pneumothorax. If you go above the 12th rib, it's anywhere from about 5 to 10%, depending upon the series. There was another study that was done looking at supine versus prone flexed. These were 30 patients. They found, once again, the track length was shorter in both prone positions. The maximal access angle, they found really no difference. The access field, which is, once again, the number of potential spaces that you could go into the kidney between the posterior superior iliac crest and the ribs, was larger with the patient in the prone flex position. Recently, there were a couple other studies that have been published which have called into question the superiority of the prone position. There was a study of 37 PCL patients, and they found that the prone decubitus position was associated with more potential organ injuries. There was a recent study, I think, this was out of you guys, out of Irvine, yeah, in which they looked at 19 patients who underwent percutaneous cryoablation, and they found in the prone position the colon was actually closer to the hilum of the kidney and located more posteriorly in the prone position, and that the lung actually expanded a little bit lower over the right kidney, potentially increasing the risk of a thoracic complication. So the summary of this is that these studies show that there is basically no clear answer, and that some studies show one position benefits from an anatomical standpoint and others don't. What we do know is that in general the prone position is definitely associated with a shorter access tract. Obviously there's a greater number of potential access sites because you can go anywhere above the rib all the way down to the posterior iliac spine. But once again, the risk of either thoracic complication or visceral injury is a little bit equivocal from looking in the literature. Fortunately, the rates of colon injury and liver or spleen injury are very low regardless of position. All right, so, and then lastly I want to talk about, well, that's great. What does the data show? So there have been 4 prospective comparative studies looking at prone versus supine PCNL. The first one was published in 2008 in European Urology, and they looked at 39 patients who were done in the supine position with the ipsilateral side bumped up with the 3-liter saline bag, and they compared those to 36 patients who were done in the prone position. They included patients who had either a single or multiple stones that were felt to be treatable via a single access site. So these were not patients with Staghorn stones. These were patients with stone diameter greater than 2.5 centimeters and a BMI less than 30, which in the United States would pretty much exclude almost everyone. And then, once again, they didn't approach Staghorn stones, and they didn't do patients with complex renal anomalies. And what you can see is that the 2 groups are relatively comparable with regard to stone size, gender, and BMI. And the only significant variable that was different between the 2 groups was operating time, in that the prone position had a longer OR time than the supine position, and that was statistically significant. Otherwise, the stone-free rate and complication rate was no different between the 2 studies. But I would argue that once again, this is a highly selected population, so these are patients that are relatively thin. As we talked about, one of the problems with supine PCNL is that it has a longer tract length, which isn't as big a deal when you're treating patients who have a BMI less than 30. And it's a relatively less complex stone burden. There was another study looking at 40 patients in the pure prone position to 40 patients in the pure supine position. Once again, these were stones that were relatively non-complex that could be treated with a single access site that had a diameter greater than 2 centimeters. They ruled out any patients with renal anomalies, pediatric patients, and patients who are on immunosuppression. Once again, like the other study, there was no real significant variable difference between the 2 patients in terms of, or the 2 groups between age, BMI, and stone size. What they found, once again, was that the prone position was associated with a longer operative time. However, the supine position had a much higher transfusion rates, in that 20% of the patients were transfused, whereas only 7.5% in the prone position were transfused. And the authors didn't really give a good, clear explanation for that, why that was. And one of the things you wonder about is just whether they were on the learning curve with the supine position or whatnot, but they didn't really say. But that's a pretty high rate for transfusions given the fact that it's a single puncture. The next study was, once again, prospective randomized trial of 62 patients done in the prone position compared to 60 patients who were done in the supine position. Stones greater than 2 centimeters. They also included larger proximal ureteral stones, and the preoperative characteristics between the 2 groups were no different. The vast majority of patients were done subcostal, and they were almost entirely either into the lower pole or into the interpolar calyces. And this study was somewhat different than the other in that they actually found that the prone group had a shorter OR time. Stone-free rate was better in the prone position, and as a result, fewer patients required a secondary procedure because the stone-free rate was lower. So this study was in favor of prone over supine. The last study involved 100 patients, which were done in the supine lithotomy position versus the pure prone position, similar inclusion and exclusion criteria, and once again, there was no difference in preoperative characteristics between the two groups. One of the things that made this study interesting was that it was done, they looked at a variety of hemodynamic changes, and what they found was that the blood pressure did drop slightly for patients when they were in the prone position. Their heart rate increased, and there was a slight increase in the peak inspiratory pressure. But these weren't clinically significant changes in hemodynamics. They then looked at complications. They found there was no significant difference in complications, and for some reason the hospital stay was longer in the prone position versus supine, and that included for patients who did and did not have intraoperative complications. So in summary, the vast majority of cases are safe and efficacious regardless of whether you're doing it in the supine or prone position. You may want to consider doing it prone if the patient's obese and they can tolerate the prone position, or patients with more complex stone burden, simply because you have more access options. If you need to go above the ribs, you can, whereas it's much more challenging in the supine position. But more important than all these things, than position, is really your provider comfort. So if you're trained to do it supine, that works fine. If you're trained to do it prone, it doesn't matter. It's just whatever experience is far more important than the actual position itself. Thank you.